Hello, and welcome to the American Lung Association's Lung Force Community Connections webinar series. Today's topic is the ABCs of asthma from school years to adulthood. We're glad to have you all tuned in today to hear about this important and timely topic. Before I turn the program over to our moderator and esteemed speaker, there are a few housekeeping items to cover. First, this call is live on Facebook and Zoom. This call is being recorded. Also, today's session is meant to be interactive. We want to hear from you. To do this, put your questions in the chat box for those tuning in via Zoom and in the comments section on Facebook. Thank you to those who have already sent in your questions. Dr. Scher will be answering them shortly. Finally, if we're unable to answer all of your questions, we will send out a follow-up email with answers. Facebook listeners, check the chat for instructions on how to send us your email to be included. Thank you again for joining in today, and thank you to our partners at DiMaggio Children's Hospital, Memorial Healthcare System, and the Jean and Sue Folden Charitable Trust for making today's session possible. I will now turn the program over to today's moderator, Casey Reed.
Good afternoon, and thank you to American Lung Association for giving DiMaggio Children's Hospital the opportunity to share this very important information with our community. Our speaker today is Dr. Herschel Scher. Dr. Scher is a board-certified pediatric pulmonologist, and his patients represent the full spectrum of pulmonary conditions and allergies from infancy to adolescence. The main conditions he treats are asthma and cystic fibrosis. Dr. Scher's research interests include clinical pharmacology of drugs used in respiratory medicine and respiratory infections in cystic fibrosis patients. He is currently running the DiMaggio Children's Hospital Pulmonology Research Division, where he participates in national and international research studies. Seeing very sick patients recover and being able to make a difference in their lives is very rewarding for Dr. Scher. He most enjoys the basic interaction with the patient and the family and improving the lives of the children. He looks forward to coming to work every day and bringing smiles to their faces. In his spare time, Dr. Scher likes playing golf, watching sports, reading, and the outdoors.
Good afternoon, and thank you to the American Lung Association for inviting me to present today. Next slide. As we can see, that asthma is a common condition affecting 22 million Americans. It's about 8% of the population, 10% of children, and about half of these patients have at least one asthma exacerbation annually. It also entails a lot of lost days of school, a lot of lost work, and it's very costly, estimated around $60 billion a year for asthma. Next. So the basic asthma pathophysiology, there are two elements. The one is the airway hyperresponsiveness, which is where the muscle in the airway going to spasm and narrow the airway, and inflammation. We have approximately 20 different widths of airways. So the central airway, the trachea, is the largest and the widest. And as we go towards the periphery, airways get narrower. And as part of the inflammation, there's swelling of the airway mucosa, the lining of the airway, and a lot of mucus being produced. And the triggers that can facilitate this are allergens, exercise, cold air, irritants such as particulate matter, and viruses, and then create symptoms of coughing, wheezing, shortness of breath, and chest tightness. So this just shows you how complex the pathway it is. This is showing where an allergen is precipitating the event. There's certain white blood cells that are involved in this reaction, and they release substances, and that this then activates nerves, which then result in the bronchospasm, which you see in the airway muscles at the bottom, the blood vessels which become inflamed and leaking fluid, and then mucus being produced. And this shows the whole cascade of inflammation with extra mucus being produced and the nerves causing the bronchospasm. Next. And this is just a diagrammatic depicting that on the left-hand side is a normal airway where there's no muscle tightening, and we can see that the airway lumen is patent. And on the other side, an asthma airway, it's depicting some muscle spasm with narrowing airway, and we can see that the lining and the airway is much narrower due to the airway swelling with the red swollen area and the mucus being produced. And that's what we see typically in asthma. And this is just showing in terms of children with true asthma, about 30% develop symptoms within the first year of life, about 40% will become symptomatic between 1 and 3 years of age, and about 30% after the age of 3. These are various precipitating factors. Commonest in children are viral infections and genetic family history of irritants such as smoke, air pollution, chemicals, dust, certain medication, or that tends to be more in adults, but there are a couple of cardiac medications that may cause bronchospasm, animal dander, and stress. And also anxiety can provoke asthma attacks. Just depicting the symptoms: wheezing, coughing, shortness of breath. Typically, in children, many times it's due to a virus. Children may perceive chest tightness as chest pain. They're most symptomatic at night, typically around midnight to 1, 2 in the morning. Difficulty breathing, tachycardia, rapid heart rate, and that may also be induced by the bronchodilators and dyspnea or shortness of breath. This is just showing you, because sometimes it's very hard to differentiate, is it just due to a cold, flu, hay fever, allergic rhinitis, and obviously now we need to think about coronavirus. So this is just showing the difference that typically, if, in terms of asthma, if it's not a viral infection, you usually don't get fever. You do get coughing and shortness of breath and wheezing. And usually that you don't get muscle aches, unless there's viral infections or stuffy nose. Whereas with the others, with a cold, you're going to get more of a stuffy nose and you'll get muscle aches. And obviously with coronavirus, we can get high fevers, the coughing, shortness of breath, aches and fatigue. Next. This is just showing the prevalence. This is data from the CDC showing in the various states of the country. And I'm in South Florida, and we are sort of in the middle, around 7 to 8% of the population have got asthma. And whereas the Northeast, it's higher, between 9 and 12%. And this is showing that the asthma prevalence, and prevalence is the actual number of patients that have it. And we see over the past 20 years, it actually has been decreasing. The light blue line at the top is children. The darker blue line at the bottom is adults, and the red line is the all ages. And we can see it's gone down about 10, 12% within the past 20 years. And this is just showing by sort of age, the prevalence of again, in terms of male and female distribution. And we see that in the younger ages, it's more males, and as we get older, it tends to be more females having persistent asthma. And hospitalizations, it's commonest in the youngest children, but it's also adults, and it's in the older adults. And we can see that as you get older, in terms of childhood, there's less hospitalization, but then it picks up again with advancing age in adulthood. And this is the asthma classification. So asthma is either intermittent or persistent, and then persistent is further then broken down to mild, moderate, or severe, and it depends on the frequency of symptoms, how many days a week, whether there's nighttime awakening, how frequently you need to require your short-acting bronchodilators, and whether it interferes with activity, and then it's also there's the using the parameters of lung function. And the treatment will then depend on the severity of the condition of the asthma. And this is actually the American girl who came out with the sort of an asthma kit. And this is actually very interesting, and it's a very good thing for young children because it shows them samples of spaces and of inhalers and action plan. And we actually, as pulmonologists, think that this is a good tool to teach young. Obviously, this is more with the girls, but this is a very good tool because this is fairly real and covers many of the medications that we use. Next. So this is again showing the step up, and this is the latest of the global initiative for asthma. What has changed recently is that in the past, intermittent and the mild persistent asthmatics were treated with inhaled steroid, with bronchodilators for intermittent. Once you got to mild persistent, you were treated with daily steroids, whereas now they're recommending using Symbicort, which is one of the combined medication, inhaled steroid long-acting bronchodilator, even in the mild persistent, and using it only when symptomatic and not as maintenance medication. And then obviously, as you step up in more severe asthma, one would need more medications, going from low to medium to high dose corticosteroids, with sometimes adding additional medications, including the newest immunomodulator subcutaneous injections. And this is again, we can actually skip over the slide, but this is showing the GINA recommendations again in terms of the stepping up. And this is showing you just from the allergy network, showing that various inhalers are the top corner of the short-acting bronchodilators, and they're the longer-acting bronchodilators, which tend to be used mostly in adults. Then in the various inhaled corticosteroids, which come either as metered-dose inhalers or dry powder inhalers, or the dry powder disc, and then there are the combination inhalers. Many of these are only used in adults, and then there's muscarinic, which is also bronchodilators, just works on a different mechanism. And then at the bottom of the biologics. And then the thermoplasty, that's used in adults. We don't do that in pediatrics. And this is just showing you can either administer the medication by nebulizer or by inhaler. And since whether you use the nebulizer inhaler with superb technique, you're only getting about 15% of medication. Therefore, with the inhalers, we use a spacer, and we encourage all, even our adolescents, to use a spacer with the inhalers. And the other interesting thing is, with some children don't cooperate with the nebulizer, and if you move the nebulizer cup about 2 inches away from the child, you may lose up to 50 to 60% of the medication. Next. The last slide just shows the difference where the top, where you don't use a spacer, you see a lot of the drug is actually being swallowed in the stomach with very little in the lungs, whereas if you use the spacer, and the idea of the spacer is that it eliminates the coordination or the poor coordination factor. You see that majority of the medication is going into the lungs with very little in the stomach. So that's why we do encourage using spacers. And the basic goals of management is that symptom-free, no exacerbations, you're not missing school and work, you're maintaining good pulmonary function, minimal use of medications, limited side effects, and we're meeting families' expectation of asthma control. This is a joint effort between the physicians and the family to maintain good asthma control. What can we do as parents? We need to empower children, and they need to learn about their asthma, why they're using various medications, names of the medications, and what the medications do, and use the medication appropriately. I find that some parents and some patients get confused between the maintenance controller medications and the rescue bronchodilators. Some parents can see asthma warning signs in their child may be a bit more pale, some parents have told me, or other signs. And what we need to do in terms of avoiding asthma exacerbations, encourage influenza vaccine, eliminate smoke exposure, whether it's tobacco, whether it's wood burning fires, and vaping has become a problem recently. Eliminate allergens, and it's just a few there, house dust mites, pets and that, and odors are also bad irritants for the airway. Maintaining good control, adhere with medications, ensure your equipment is working, refill prescriptions, and obviously we realize that it's expensive, so it does certainly help if one has health insurance, because the price of these inhalers is, it's very expensive. And this is just basically showing that this was a study that was done in Tucson, Arizona. The infants with transient wheezing, the young infants where the asthma just caused, or it's not really asthma, it's just wheezing inducing bronchospasm, usually recovers by 3 months of age. Then there's the persistent wheezing with atopy, which is allergy, and those are the persistent ones which persist into adulthood. And then those which are not allergic but have true asthma, they usually may resolve by school age, particularly in the boys. And then there's the seasonal asthma. And then we find that after puberty, asthma is more prominent in girls. And then you can get new onset asthma in adults. Thank you. I think it's now time for some questions.
Our first question is, do we have any information how much of a decrease is in chronic lung disease in adults and patients who reliably use controller medications in childhood?
So, being a pediatric pulmonologist, I don't have that much information on adults, but what I can tell you is if you're taking medication on a regular basis and your asthma is controlled, then you probably will be controlled through, or certainly through early adulthood, and they should be, you should have fairly good lung function. I have heard that sometimes with increased age, there may be a reduced response to inhaled steroids, and the immune system may not be as effective and become blunted with age. But as I think I would defer that question more to an adult pulmonologist, since I deal exclusively with children.
Thank you. Our next question is, how young can asthma be diagnosed and how is it diagnosed? You're on mute, Dr. Scher.
Okay. So asthma can be diagnosed as young as infancy. If they have typical symptoms of coughing, wheezing, shortness of breath, most of the time in children, the bronchospasm is due to viruses. But if there's a strong family history, or infants who have eczema tend to have more sort of asthma that's not viral induced. We can start doing pulmonary function testing, which gives you an objective measurement around 5 to 6 years of age. But I know that some physicians are reluctant to diagnose asthma early because of this overlap with just viral-induced bronchospasm. But as I said, there are children where one could be reasonably confident, even in infants or toddlers. And in treated, one needs to treat with the controller meds, which are either some inhaled corticosteroid or a leukotriene antagonist. And there are a few of those on the market. And then, so those are the maintenance treatment that need to be taken daily, even when the patient's asymptomatic. And then there's the rescue medications, such as the bronchodilators, which are taken as needed when the patient's symptomatic. And there may be times where they have exacerbations that they may need a short course of oral corticosteroids. I personally don't have any patients who require long-term daily oral steroids, but there are some patients who require that. And now more recently, we have immunomodulator, which are injections that are subcutaneously given every 2 to 4 weeks, which have made a significant impact on asthma control in that they block the eosinophils response, which is the major cell involved in, one of the major cells involved in asthma allergy, or they block the effects of these interleukins, which are substance released by these cells and which precipitate the asthma or allergy exacerbations.
Thank you. Our next question is, are there diets or certain foods that can help prevent asthma symptoms or attacks? You're on mute, Dr. Scher. Dr. Scher, you're on mute.
Asthma particularly is not caused by foods. Foods usually would cause more with eczema. There are families that a frequent question that I get is, should I eliminate milk from my child's diet because it may cause that? There's no proof that cow's milk will cause asthma. It may cause a little bit more mucus, but certainly not going to cause asthma. So no, there are no foods or diets that need to be for asthma per se. Obviously with eczema, or if your child is certainly allergic to, definitely has a cow's milk allergy, it may be worthwhile removing cow's milk from the diet, but usually you don't need to change a diet.
Okay, our next question is, if your child's school doesn't have a mask mandate, does this pose extra risk for an asthmatic child?
No, there's no proof that that a mask will sort of cause problems with air exchange, obtaining oxygen, or retaining carbon dioxide. In fact, and I personally think that a mask is a good idea, but no, it should not create a problem in terms of breathing or making patients more short of breath. It may be more uncomfortable, but it does not. There's no evidence to suggest that it will cause respiratory difficulty in any, whether children or adults that I'm aware of.
Our next one, could daily medications like Flovent help protect from certain COVID symptoms?
So there actually is some evidence that the daily meds may, and that these inhaled corticosteroids may actually reduce the viral replication, so the virus may not replicate as often. And there's also downloading and downregulation of what's called the angiotensin converting enzyme 2, which is the sort of target that the virus, that the COVID virus binds to and is then incorporated in the cell. So yeah, it certainly may improve asthma control.
Okay, it was, sorry to back up to the last question, but is it safe to send them back to school if there's at that school, particularly?
You were cutting out. I didn't hear the full question, Casey.
Is it safe to send them back to school if there is no mask mandate at that school, particularly for an asthmatic child?
So the actual evidence at present is that there is not a significant risk for mild or possibly moderate asthmatics and COVID infection. So I think that school is, the children learn best in the classroom. But so I know that the incidence of COVID is increasing in the population with this new Delta variant, and that there are more children getting asthma. But I would say, as a general statement, yes, it would be safe. I also would think that I'm a believer that a mask is a good thing. I know that certain states have mandated differently, but I think that there is safe and common sense, washing hands and if possible, if one can social distance, it's a good idea. And obviously hand washing and using sanitizer on a regular basis. But I think it's also important for families to discuss with the school. Good communication is very important, and find out what the school's policies are and what they are doing to reduce the children's risk of getting COVID in terms of hygiene, screening patients who may be symptomatic, and what their plan is if they do have students who test positive for COVID. But overall, I find that when children did not attend school, it really affected their psyche. And the majority of my patients tell me that they are much happier being in school. They're able to learn better than to learn on Zoom. When the vaccine becomes available for various age groups, I do encourage the COVID vaccine.
Thank you, Dr. Scher, for all of this vital information. It's super timely as kids start to head back to school as early as this week. Thank you once again to American Lung Association for having us this afternoon, and we would like to turn it back over to Nicole.
Thank you, Casey and Dr. Scher, for the great information you provided. And as Casey said, this topic was incredibly timely. And so were some of those great answers as we send our kids back to school. And thank you all for attending today's American Lung Association's Lung Force Community Connections event. On behalf of the American Lung Association, we'd also like to thank our partners at Joe DiMaggio Children's Hospital, Memorial Healthcare System, and the Jean and Sue Folden Charitable Trust for bringing this educational series to our local community. For the questions that we were unable to get to today, be on the lookout for email coming up in the upcoming weeks with responses. If you would like to reach out to Dr. Scher or the Joe DiMaggio team with your questions, contact information will be added to the chat. To learn more asthma management tips and techniques, the American Lung Association also offers a free course called Asthma Basics, and a link to this program will be put in the Zoom chat as well as the Facebook comments. Also, don't forget to follow the South Florida American Lung Association on Facebook for announcements regarding our next Lung Force Community Connections event planned for November. The topic will be lung cancer and COPD. More to come, so please follow us at Lung Sofla. That's Lung, S-O-F-L-A, for details. or this page that you're on if you're watching on Facebook. Until next time, thank you, Dr. Scher. Thank you, Casey, and all of you who tuned in today. Together, we can improve life one breath at a time. Have a great day, everyone.